Hello everyone. Today we are going to talk about Toxidrome. This was also the question which was asked in DRNB Critical Care exam in 2022. So intensive care physician who treat the poison patient should have systematic approach to evaluation and the management. Accidental or the intentional poison from both illicit or illicit substance can lead to wide range of symptoms and clinical findings. Hence, history and physical examination, they are of great importance in recognition of poison patient. So initial management should be focused on initial management should be focused on the acute stabilization and supportive care till the correct substance is identified. The plan of management is to provide supportive care, prevention of poison absorption, use of antidote wherever is indicated, and enhancement of elimination technique. So, initial assessment, our first priorities are, as with any unstable and critically ill patient, the resuscitation, that is airway, breathing, circulation, with basic life support takes a priority. In addition to resuscitation, the intensivist must consider the two crucial issues that may arise with severely poisoned patients, that is, preserving the operational capacity and ensuring the safety of healthcare workers. In poison patient, diagnostic evaluation and therapeutic intervention often are initially initiated simultaneously. About risk assessment, following initial resuscitation and stabilization, risk assessment is performed to predict course of clinical toxicity, interventions required, and the patient disposition. It is formulated using history, examination, and ancillary test results. The risk of poison patient can be assessed by gathering the data, either substance based or system based. The substances belonging to particular class of the toxin produces characteristic combination of symptom or sign, which is called as toxic syndrome. The toxidrome oriented physical examination may provide valuable insight into class of toxin involved. About diagnostic tests, though toxidromes are created to assess diagnosis, a particular patient may not have all the symptoms associated with given toxidrome, and always some discrepancies are noted after examination of poison patient. So history may be inaccurate, and hence following lab tests should usually be opted, like complete blood count, basic serum electrolyte, blood urea nitrogen and creatinine, liver function test, serum electrolyte, ABG, ECG, and urine pregnancy test in all women of childbearing age. Measurement of drug and toxin concentration in body fluid is not required in most poison, but in some exposures, it does influence the management. The list of drug concentration that may assess the patient assessment and management is shown. So, toxicology screening assay are available commercially. However, the results seldom directly influence the patient management and they have their own limitation. Most of the tests use enzyme immunoassay that only detects the typical drug within the class. The time frame at which this screening assay are performed is major concern. So the drug consumed by patient may take days to week to be detected after exposure. So positive test may not account for current clinical findings. High possibility of the cross reactivity among different group of drug occur. Negative drug screen does not exclude an exposure, and sampling error is also major limitation. On medical legal ground, performing toxicology screening may serve the purpose. In contrast to the rapid immunoassay screen, comprehensive qualitative toxic screening of urine, blood, and other body fluid is done by liquid and gas chromatography and mass spectrometry. So these are the common toxic. If it is symptomatic, then the features are like a patient will be hyper alert, agitated, hallucination, paranoia, pupils will be dilated. Then patient will show the hyperthermia, tachycardia, hypertension, and widened pulse pressure. Other manifestations will be diaphoresis, tremors, hyperreflexia, seizure. Examples are cocaine, amphetamine, ephedrine, theophylline, and caffeine. Then anticholinergic, the symptoms will be agitation, hallucination, delirium, coma. On examination, we'll find the vidriasis, hyperthermia, tachycardia, hypertension, tachypnea. There will be the skin will be dry, flush, dry mucous membrane, decreased bowel sound, urine retention, and myoclonus. And the examples of these agents are antihistaminic, TCA, anti-Parkinsonism agent, atropine, and antispasmodic. Then third toxidrome will be hallucinogenics. The clinical symptoms will be hallucination, perceptual distortion, depersonalization, and agitation. Then pupils will be dilated. The other symptoms will be hyperthermia, tachycardia, hypertension, tachypnea. Then there will be the nystagmus. The examples of this will be phencyclidine, MDMA, and MDE. The fourth class of drug is opioids. Mental status, the features will be CNS depression, coma. Pupils will be myotic. Then patient will be having bradypnea, apnea. The other symptoms are hyporeflexia, pulmonary edema. The examples of this class of the drug is heroin, morphine, methadone, and diphenhxylate. Then the next class is sedative hypnotic. The features will be CNS depression, confusion, stupor, coma. The vitals will be normal. Patient will be hypothermic, bradycardic, hypotensive, bradypnea, and apnea will be there. Hyporeflexia will be there. And the class of drug will be benzodiazepine, barbiturate, alcohol, and the zolpidem. Then the next class of drug is cholinergic. The symptoms will be confusion and coma. The on examination, pupils will be myotic. Then features will be bradycardia, hypertension, tachypnea, hypotension, and bradypnea. The manifestation will be salivation, urinary fecal incontinence, diarrhea, emesis, diaphoresis, lacrimation, GI cramps, bronchoconstriction, muscle fasciculation, weakness, and seizure. The examples of this class is organophosphate, carbamate, insecticide, nerve agent, nicotine, physostigmine, and edrophonium. Then the next class of drug is serotonin syndrome. The patient will be having confusion, agitation, coma. Pupils will be dilated. The symptoms will be hyperthermia, tachycardia, hypertension, and tachypnea. The other manifestations are tremors, myoclonus, hyperreflexia, uh, clonus, diaphorosis, flushing, trismus, rigidity, diarrhea. Then examples are MAOA inhibitor, SSRI, meperidine, dextromethorphan, and TC. Commonly measured drug concentrations are acetaminophen, carbamazepine, carbon monoxide, digoxin, ethanol, ethylene glycol, iron, lithium, methoglobin, methanol, methotrexate, organophosphorus, paraquat, phenobarbital, phenytoin, salicylate, theophylline, and valproic acid. Then care is airway management, the loss of airway protective reflexes, and concern for aspiration and presence of respiratory failure dictate the need to secure the air. Unless the patient is moribund, rapid sequence intubation with pre-oxygenation and the neuromuscular blockage is the best approach to securing the air. It should be accompanied by tracheal intubation. However, either due to inability to adequately pre-oxygenate the patient or concern that patient may be difficult to intubate and strategies aside from RSI should be considered. Delayed sequence intubation should be used as an alternative method to RSI. It comprises of administration of sedative that do not blunt the airway reflex, followed by the brief period of pre-oxygenation before administering paralytics. Orotracheal intubation, if possible, is preferred over nasotracheal intubation for many reasons. Nasotracheal intubation increases the incidence of sinusitis, purulent and serous otitis, ventilator-associated pneumonia, and is technically more difficult compared with the orotracheal intubation. An alternative strategy for securing airway and the means to establish surgical airway, if necessary, must be immediately available. Now about respiratory support, several toxins interfere with the oxygenation and ventilation. Hence, adequacy of respiration must be assessed immediately after airway is secured. When determining the ventilator setting, the lung protective strategy should be employed. Lung protective strategy prevents the development of ARDS from barotrauma and oxygen toxicity. While these strategies are commonly used in ICU, they have not been studied in poison patients. About circulation and hemodynamics, after establishing the airway and supporting the respiratory function, the next is the assessment of the circulatory status. In the poison patient, cardiovascular abnormalities commonly seen as hypertension, hypotension, cardiac arrhythmia, and conduction disturbances. Elevated blood pressure in poison patient may or may not be the result of exposure to any of many substances, of which most common cause of elevated blood pressure are withdrawal, that is benzodiazepine and ethanol withdrawal, discontinuation of therapeutically prescribed medication such as clonidine and minoxidil, causing rebound hypertension and inadequately treated or untreated underlying hypertension. The treatment of hypertension is determined by its underlying cause. When hypertension is caused by overdoses of drug with direct adrenergic activity, such as amphetamine, ephedrine, and pseudoephedrine, direct vasodilators such as phentolamine and nitroprusside should be considered. When hypertension is caused by drug with indirect adrenergic activity or by drug of abuse withdrawal, sedation with benzodiazepine should be considered. Abnormal hemoglobin and toxins that disrupt the mitochondrial electron transport chain prevent the use of oxygen at molecular level, resulting in histotoxic hypoxia and severe shock. So, the elevated plasma lactate concentration accompanying the metabolic acidosis is often marker of this toxicity. Myocardial depression, dysrhythmia, conduction abnormalities may cause shock from the impaired cardiac contractility. An ECG should be obtained in all poison patients to assess any cardiac abnormalities, which may give clues as to poison and severity of poisoning and the treatment. So the toxin causing dysrhythmia, that is tachycardia. If it causes the narrow QRS complex, then it is because of amphetamine, anticholinergic agent, and theophylline. The wide QRS complex is a result of antihistamine, cocaine, propoxyphene, sodium channel blocker, and tricyclic antidepressant. Then bradycardia, if it is causing the narrow QRS, then it is resulting of alpha adrenergic lytic agent, beta adrenergic blocking agent, calcium channel antagonist, cardiac glycoside, class 1A antiarrhythmic, sodium channel blocker. If it is causing wide QRS, then it is because of the beta adrenergic blocking agent and calcium channel antagonist. Fluid resuscitation of poison patient must be individualized. Initial resuscitation include the administration of intravenous crystalloid fluid whenever indicated. Vasopressor infusion should be started as early as possible in the course of resuscitation. In distributive shock or cardiogenic shock, administration of vasopressor or inotrope is more appropriate than simply administering fluid. Bedside sonography is useful tool to determine volume responsiveness and to estimate cardiac contractility to further guide resuscitation. There are very little data regarding the optimal vasopressor agent in poison patients. The choice of vasopressor must be made on patient profile and clinical ground. Noradrenergic vasoactive drugs are the more effective therapy for shock caused by beta-adrenergic blocking agent and calcium channel agonist. Glucagon, the peptide hormone that is produced by the alpha cells of pancreas, stimulate adenyl cyclase, which in turn increases intracellular CMP through non-adrenergic mechanism. This increase in the CMP causes increase in the intracellular calcium, which leads to positive chronotropic and inotropic action. Numerous case reports and lab investigation describe glucagon's effectiveness in reversing hypotension caused by overdoses of beta-adrenergic blocking agent and calcium channel antagonist. A glucagon dose of 5 to 10 mg administered intravenously over 10 minutes should be followed by glucagon infusion, that is 3 to 15 mg per hour. An antiemetic should be provided with the glucagon as it decreases lower esophageal tone, which causes emesis. More recently, high-dose insulin euglycemia therapy is used to treat beta-adrenergic blocking agent and calcium channel antagonist toxicity. The pathophysiology of calcium channel antagonist toxicity is decrease in insulin release from pancreatic beta cell, causing insulin resistance in myocardium and changes in the myocyte metabolism from the fatty acid to carbohydrate. High dose insulin euglycemia therapy improves the myocyte use of carbohydrate as an energy source and hence increase the cardiac contractility and improves perfusion. The lipid emulsion therapy is one of the most recent advances in the care of critically ill poison patients. It was used as treatment of patients with local anesthetic toxicity. It has been used in the management of toxicity from other poisons. There are multiple reports of lipid emulsion therapy reversing toxicity of calcium channel antagonists, tricyclic antidepressant, benzodiazepine, anticonvulsant, and beta-adrenergic blocking agents. Extracorporeal membrane oxygenation is indicated in poison patients in refractory shock who fail conventional treatment. In poison patients, ECMO served as a bridge until toxins are metabolized and eliminated, at which time the patient should regain normal cardiovascular function. Although higher cost and adverse effects are associated with ECMO, recent advances in the technology have made this more practical alternative in refractory shock patients. Now about decontamination, gastrointestinal decontamination. Gastrointestinal decontamination once the mainstay in the management of the poisoning and is no longer recovered. It is generally considered in patients who present very early and for those patients who have taken large and dangerous overdose where antidote does not exist. Ideally, GI decontamination should decrease the absorption of many ingested toxin, but its use is not associated with improved outcome. If GI decontamination is attempted, it should be done as early as possible in emergency department. The patient is very unlikely to benefit from decontamination if it is started in the ICU. And then activated charcoal. Activated charcoal is commonly used decontamination. It is manufactured in the two-step process, starting with the pyrolysis of various carbonaceous materials. Then, by treating at high temperature with oxidizing agents such as steam and carbon dioxide that activate it and increase its absorption capacity. Toxins within GI lumen are absorbed into activated charcoal and carried through the GI tract, limiting its absorption. It doesn't effectively absorb metal, corrosive, and alcohol. The decision to give activated charcoal requires individual patient risk assessment and is not considered as a routine management. Now about whole bowel irrigation. Whole bowel irrigation is another technique of decontamination which work by enhancing flow of toxin through the gut. It can be done by placing nasogastric and orogastric tube and administering large amount of 1 to 2 liter per hour of osmotically balanced polyethylene glycol solution until patient has at least 2 clear and liquid stools. Unlike other form of GI decontamination, whole bowel irrigation may be started or continued in the ICU. Body packers are traditionally treated with the whole bowel irrigation. Body packers are individualized to ingest large amount of packets of illicit drug for illegal per transportation. If there is any accidental packet leakage, lethal amount of the drug can be absorbed into body packer system, which can be life-threatening. So whole bowel irrigation should be initiated in order to Remove packets as soon as possible, given the life-threatening risk associated with even single packet leakage. Contraindications include patient with the ileus and obstruction or injury to the GI tract. Now, elimination, multi-dose activated charcoal. Multi-dose activated charcoal is used to enhance elimination of various ingested toxins. Multi-dose activated charcoal may be benefit the patient at risk from delayed absorption due to ingestion of delayed release product. Patient who ingest toxin that undergo enteroenteric or enterohepatic circulation may benefit from multi-dose activated charcoal. The intrahepatic circulation absorbs substances are secreted into bile and then into small intestine before being reabsorbed. In enteroenteric circulation, absorbed substances are secreted into intestine before being reabsorbed. So by administering multi-drug activated charcoal, charcoal can absorb toxins that are secreted into intestine before being reabsorbed, thereby enhancing elimination. Multi-dose activated charcoal is generally administered at a dose of 0.5 gram per kg following initial standard dose of charcoal. Now about urine alkalinization. Alkaline urine favors the ionization of acidotic drug within the renal tube, preventing reabsorption of ionized drug back across the renal tubular epithelium and enhancing elimination through the urine. Urine alkalinization is the most effective for weak acid like salicylate, phenobarbital toxicities. Pre-existing fluid overload, renal impairment, and hypokalemia are contraindication to the urine alkalinization. It can be instituted as follows. Correct any existing hypokalemia. Administered 1 to 2 milliequivalent per kg of IV sodium bicarbonate bolus. Infuse 100 milliequivalent of sodium bicarbonate mixed with 1 liter of D5 at 250 ml per hour. A total of 20 MEq of potassium chloride may be added to maintain normocalin. Check urine pH every 15 to 30 minutes, aiming for pH of 7.5 to 8.5. Further IV bolus of sodium bicarbonate may be warranted if sufficient alkalinization of urine is not reached. Then about extracorporeal removal technique, including hemodialysis, hemofiltration, and continuous renal replacement therapies, have limited indication in poison patients. A toxin must possess a number of properties to be effectively removed by extracorporeal technique. It should have a low volume of distribution, low molecular weight, low protein binding capacity, and low endogenous clearance. So this is the flowchart of extracorporeal removal of toxin. So we need to assess the risk and benefit of extracorporeal technique. If the risk is more than the benefit, then the no extracorporeal support should be there. If benefit is more and other, then we need to see when other alternative therapies are available or not. If other benefits if they are not available, then we need to see the volume of distribution is how much it is there. If it is more than 1 to 2 liter per kg, then there is no use of extracorporeal therapy. If volume of distribution is not more than 1 to 2 liter per kg, then we need to assess the protein binding. If protein binding is more than 95%, then there is a use of, then go for plasma exchange. If it is between 80 to 95%, then go for hemoperfusion. Then we need to see the molecular weight. If molecular weight is less than 10,000 Dalton, go for hemodialysis. If molecular weight is between 10 to 50,000, hemofiltration. If molecular weight is more than 50,000, plasma. Then antidote. Most poison patients can be treated with standard supportive care. But in few circumstances, specific therapy or antidote are required. List of antidote of common poisoning given in the National Poison Information Center, which is an integral part of National Poison Control Program. So if it is a OP poisoning, which involves organophosphate, carbamate, and organochlorine, atropine, pralidoxime, cholestyramine. If it is a lead poison, then the antidote is dimercaprol, D-penicillamine, and calcium disodium editate. If it is mercury, then dimercaprol, dimercaptosuccinic acid, D-penicillamine, and dimercaprol. If it is arsenic, then the antidote is dimercaprol, D-penicillamine. If it is methyl alcohol, the antidote is ethanol, folic acid, and the folinic acid. If ethylene alcohol, then the antidote is ethanol, pyridoxine hydrochloride, folic acid, and thiamine. If it is a cyanide, then the antidote is amyl nitrate, sodium trisulfate, hydroxycobalamin, dicobalt ethylate. Uh, if there is a methemoglobinemia producing agents like nitrite, nitrate, dapsone, copper, aniline, chlorate, and naphthalene. Then the antidote is methylene blue. If in case of acetaminophen, antidote is N-acetylcysteine. Then iron poisoning, the antidote is deferoxamine, benzodiazepine, flumazenil, opioid naloxone, isoniazid, pyridoxine, digoxin specific antibody. Then Dhatura antidote is physostigmine, snakebite, anti-snake venom, dog bite, anti-rabies vaccine, botulinum, antidotes. Then about ancillary support, critically ill poison patient, they are at increased risk of GI bleeding. In ICU, 75% of poison patients have endoscopic evidence of gastric mucosal injury by 18 hours after admission, with 5% of patients developing overt bleeding. So gastrointestinal bleeding prophylaxis should be started on admission to ICU and can be achieved based through the use of histamine 2 receptor antagonist or proton pump inhibitor. Poison ICU patient, they are at risk of venous thromboembolic disease if they have prolonged course requiring them to remain in the bed. Approximately 33% of ICU patients develop ultrasonographically detected DVT despite receiving prophylaxis. So meta-analysis showed that the use of heparin and pneumatic compression stocking decreases the incidence of DVT by at least 50%. Deep vein thrombosis prophylaxis should be initiated with unfractionated weight heparin, low molecular weight heparin, or compression devices as soon as patient is admitted to the ICU if prolonged stay is anticipated. The goal of nutritional support is to meet patients' nutritional need without overfeeding. Overfeeding should be avoided because excess carbohydrate can lead to increased carbon dioxide production. Enteral feeding, which help maintain integrity of gut mucosal barrier, are preferred over parenteral route. Thank you, guys.